Now, the topic of my talk is, does CGM reduce the risk of fasting? Okay, these are my disclosures relevant for this talk. And an overview of what I will be presenting today. First, we'll be looking at current CGM technology, some lessons learned from the existing literature on CGM use for Ramadan fasting, some personal case studies, and then a conclusion. So in current CGM technology, now this measures glucose levels in the interstitial fluid continuously and updates the glucose level display every 5 to 15 minutes. And it can be continuous with real-time alerts and alarms, or it can be intermittently scanned, whereby the user will need to bring the reader or iPhone or a phone applicator to scan the sensor and then have the reading. There are 3 components to the CGM, and that's the sensor, the transmitter, as well as a monitor to display the information. And the CGM can be real-time or retrospective and can provide information to detect hypoglycemia and hyperglycemic excursions with alerts and alarms for real-time CGM. It can also help the user to predict impending hypoglycemia or hyperglycemia based on the trend arrows in real time, view the glycemic variability over previous readings, and make adjustments to therapy in real time, whether it's to insulin or oral hypoglycemic agents, and whether it's, and particularly where it's a sensor augmented or closed loop insulin pumps, the insulin pump will be able to vary the basal rate based on the CGM readings. Okay. This is the flash or intermittently scanned glucose monitor in which we are familiar with. Here, the user will have the sensor, usually over the upper arm, and then use a reader or a phone app in order to scan the sensor and have the reading. And then thereafter is able to access the data on separate on the LibreView, and then the healthcare professional can also access this data. And then similarly for CGM, whether it's real-time or retrospective, you will be able to view the sensor readings. Most CGMs to date will still require some form of calibration capillary blood glucose. So the limitations of current CGM technology. Now, this is quite an important to understand because it helps the healthcare professional to explain to the user the limitations such that they are able to understand how to use the sensor and when to rely on capillary blood glucose. So the first limitation really is in the accuracy. And in terms of accuracy, we have the MAD or mean absolute relative difference. Now, the lower the MAD, the more accurate the device is. And then there is the concept of lag time. And I explain it to my patients as because the sensor is reading the interstitial glucose and not the blood glucose, it will always require some time for equilibration to take place. So if you look at the image on the right, you will be able to see the lag time. So for instance, in number 1, when glucose is rapidly changing, the blood glucose may be on the upward trend, but the sensor glucose may be lagging behind. On the other hand, in number 2, after insulin administration, the blood glucose may already be on the way down, but the sensor glucose is still showing that it's elevated. And similarly, after food or after exercise, there will always be some lag time. So it's important to set patient expectations right. In some CGMs, there may also be interference from certain medications and other factors. And the known medications which can interfere with the accuracy include things as common as vitamin C or ascorbic acid, acetaminophen, or locally known as paracetamol, lisinopril, and others. There are also many other factors which can impact on accuracy. Another important limitation to remember in CGM use is the loss of function of the sensor, which limits the lifetime of the sensor. So most sensors can be used for between 6 to 14 days, but at the end or near the end of sensor wear, there may be some loss of accuracy or loss of function. Certain CGMs may also need calibration, And this can result in inconvenience or discomfort with finger prick blood glucose testing. And then, of course, there is the issue of cost, in which locally in Singapore, as well as in Malaysia and other Southeast Asian countries, there may be a lack of reimbursement for such devices. So let's review the literature on the use of CGM during Ramadan fasting. What has the available literature taught us? Now, I think that CGM has enabled a greater understanding and appreciation of glucose patterns during Ramadan fasting. Now, in this paper by Lasan et al., the glucose excursions and glycemic control during Ramadan fasting in diabetic patients. In this study, 56 patients were looked at, 50 with type 2 diabetes and 6 with type 1 diabetes, mean HbA1c 7.2% with 7 healthy volunteers. Here, patients use the professional CGM. So this is a retrospective CGM, whereby the patient is not aware of their blood glucose readings or interstitial glucose readings. And the findings of this study showed that CGM curves showed a rapid rise in interstitial glucose after iftar. So if you look at the graph on the right, the healthy controls or without diabetes are seen as the blue line, whereby there is actually quite little fluctuation in the interstitial glucose throughout the 24 hours, despite Ramadan fasting. But in patients with diabetes, you can see that there is an initial dip, especially in the pre-iftar period, and then a rapid rise in the interstitial glucose after iftar. And the time in hypoglycemia was actually quite low, 1.11% during Ramadan, 2.4% during non-Ramadan period. This is possibly due to any medication adjustments being made. And there were no significant changes in the mean glucose, the mean absolute glucose excursions, which is a representation of the glycemic variability, time in hypoglycemia and time in hyperglycemia. You can also see that those in group 4, which are the insulin-treated group, had actually the highest mean interstitial glucose and the highest rise in the post-iftar interstitial glucose. By the same group as well, a follow-up study in 2020, whereby they looked at Ramadan fasting in insulin-treated patients, and they showed that it was associated with potentially unfavorable changes in glucose metrics. Now, if you look at the graph above, in the top right-hand corner, the pre-Ramadan is in red, and it generally showed better glycemic control. The Ramadan period is in green, whereby there is an increase in hyperglycemia risk, especially after iftar, similar to the earlier study, mean glucose as well as time spent in hyperglycemia. And there was a small risk of hypoglycemia in this insulin-treated group. And there was an increase in glycemic variability, particularly after the iftar period. The post-Ramadan period is shown in blue, and it showed that the glycemic control remains higher compared to the pre-Ramadan period. Similarly, in children and adolescents, there was shown to have some blood glucose fluctuation during Ramadan fasting. And in this study, there were 21 patients with type 1 diabetes, and 18 were on insulin pump therapy. The diabetes duration mean was 6 years, and 76% managed to fast more than 25 days. And it showed that there was actually the time spent in hypoglycemia was about 16.7%, which is 4 hours. And the fasting hours was 14.2% versus 2.5% in the non-fasting hours. And this resulted in a breaking of the fast in 15% of the days. The hyperglycemia as well was about 7 hours. So in general, there was a wider blood glucose fluctuation during the fasting and eating hours, as well as unreported hypoglycemia during Ramadan. Now, second lesson that we can find from the use of CGM during Ramadan fasting is that CGM, when combined with good patient care, results in improved glycemic outcomes. And this is a study by Dr. Hassanain's group, in which it was a prospective interventional study of patients with high-risk diabetes who insisted on fasting. And these are high-risk patients with type 1 or type 2 diabetes on insulin, gestational diabetes, stage 3, CKD, or having a history of ischemic heart disease. And in these patients, all patients received a Libre continuous glucose monitoring device, was offered to attend the clinic at any time during the study. And they were provided with diabetes, Ramadan-focused diabetes education, the Libre device, as well as pre-Ramadan dose adjustments in their medications, as well as counseled on safe Ramadan fasting. And what this study showed was that there was an improvement in HbA1c after Ramadan of 0.3%. And more importantly, in the flash glucose monitoring readings, you can see that the percentage time in range improved significantly with a corresponding reduced percentage time above range. And there was actually no statistical significant difference in the percentage time below range. In terms of the hypo events, although the number of hypo events increased during Ramadan, which as can be expected during fasting period, it was also found, I think this provides us greater insights into the risk timing of hypos during Ramadan fasting. And you can see that the hypo risk is highest actually is highest especially pre-iftar period. So between 12 to 6 p.m. As well as overnight between midnight to 6 a.m. Okay. And similarly, this is also a study in children and adolescents with type 1 diabetes during fasting, which showed that the use of such devices, because of the fact of continuous glucose monitoring, the ability to look at trend arrows and to avoid hypoglycemia, as well as to manage hypoglycemia, leads to better outcomes during Ramadan fasting. Now we'll move on to two case studies. So a few years back, a colleague of mine conducted a study whereby we used flash glucose monitoring in a group of patients, but this was in type 2 diabetes. But I thought that there are some important learning points here, which I would like to share. So in this first case study, Mr. H, 51 years old, type 2 diabetes for 8 years, fasted for Ramadan in 2019. His baseline HbA1c is 7.2%, so relatively well controlled, and on metformin as well as a DPP-4 inhibitor with preserved kidney function. There was no adjustment made for Ramadan fasting. And you can see that during Ramadan fasting, surprisingly, in a person who is not on any insulin secretagogues or insulin, there were a lot of hypos turning up here, which quite alarmed the patient as well. So in week 1 of sensor wear, you can see that actually there was not that many frequent hypos, but in this patient, you can see that he actually did some finger pricks as well. And you can see that as the asterisk shown here. So if we take Saturday, 11th of May at 4 p.m., 5.1 was the sensor reading. And when he did a finger prick, it was actually 7.1. So that was the difference of about 2 millimoles per liter. So the inaccuracies were particularly pronounced at lower ranges of the interstitial glucose, particularly near the end of sensor wear, particularly on day 10 to 14. And here you can see some alarming low blood glucose turning out, especially, let's say, 2.2, but when the patient tested with the capillary blood glucose, it was 4.3. So it is not so accurate in this patient. And the learning points in this particular case study would be the limitations of CGM, which I alluded to earlier on in my talk, particularly the loss of function, the accuracy, lag time, and possible interference, the importance of finger stick capillary blood glucose to double check, especially when symptoms do not match CGM readings, particularly at the low and at the extremes of blood glucose, whether it's hypo or hyperglycemia. I thought that was there some possible improvement in glycemic control midway to the end of Ramadan, perhaps through weight loss, improved insulin sensitivity, and this particularly perhaps may increase the hypo risk in patients on insulin secretagogues and insulin therapy. So in case study 2, let's look at Mr. A. He's a 66-year-old, type 2 diabetes for 23 years and fasted from Ramadan in 2019. His baseline HbA1c is 9.2%, so suboptimally controlled. Kidney function is all right as well, with eGFR of 87. His baseline medications is premixed insulin analog, 30 units pre-breakfast and 8 units pre-dinner. For Ramadan adjustment, the physician just swapped it over to premixed insulin analog, 8 units for pre-sahur and 30 units pre-iftar. And this is because the physician felt that the baseline control was not so good and he was being enrolled into this particular study. So he was brought back within a week of wearing the sensor in order to be able to adjust his insulin therapy further if needed. So here is a snapshot. You can see some areas of hypos coming out between midnight to 6 a.m. and also in the pre-iftar period, which is what we saw in the earlier study by Dr. Mohammed. Okay, so week 1 of sensor wear, medications are premixed insulin analog, 8 units pre-sahur, 30 units pre-iftar. Now, based on this, when he came back with the interim download at the end of week 1 of wearing the sensor, because of the dip on trending on the lower end pre-iftar, the physician decided to adjust the insulin to 8 units pre-sahur and 25 units pre-iftar. So this is the second week premixed insulin analog. These are the sensor readings for the second week based on the medication adjustment. So the learning points here, once again, would be the importance of finger prick CBG at extremes of blood glucose levels, both hypo and hyperglycemia. Now, this is in reference to 17th of May. If you can see, Friday was 4.1 at 2 a.m., but the finger prick was 5.4. And then some further on, there are some additional, I think here on Monday, 20th of May, the patient felt hypoglycemic and the sensor read as 4.1, but actually he was 3.1 on finger prick. So it's important to always check capillary blood glucose, extremes of blood glucose, and perhaps for the healthcare professionals to consider a mid-Ramadan review in high-risk patients, especially those on insulin therapy, to adjust medication doses further and to treat, and always to counsel to treat hypoglycemia correctly despite fasting for Ramadan, and to reinforce the need to break the fast so that they do not go into severe hypoglycemia. So these are my thoughts, having gone through the literature as well as some experience on the use of CGM during Ramadan fasting. Perhaps there can be a recommendation of adjusting medications based on CGM profiles during fasting, although this likely needs to be individualized because there is a wide and varied dietary practice amongst all our patients. And it also depends very much on their pre-existing diabetes history, their baseline glycemic control, the risk of hypo and hyperglycemia. Secondly, there could be possibly some changes in glucose profile during Ramadan. And although most of the studies show that hypo risk appears relatively low, and this is possibly due to the anticipated hypos and therefore a down titration of medications in anticipation of the hypos. But from the earlier case studies, perhaps there is an increase in hypo risk at the midpoint of Ramadan, and this could be due to an improved insulin sensitivity from weight loss as a result of the fasting. I think it's also important to have detailed dietary practices and a food diary basically during Ramadan to look at the impact of the dietary practices on the CGM profiles and on glucose profiles. So in conclusion, the role of CGM in Ramadan fasting, I think in the pre-Ramadan period, it enables a good assessment of the risk of fasting and aids in pre-Ramadan diabetes education. helps the physician to assess the glycemic variability of the patient, to assess the risk of hypo and hyperglycemic emergencies during fasting. During Ramadan, it enables close and remote monitoring to avoid hypo and hyperglycemic emergencies. It helps the physician to guide medication adjustment, whether it's oral or insulin, midway through and near the end of fasting. Patients can also use the trend arrows in order to look at impending hypo and hyperglycemia and avoid those events. Alerts and alarms for hypos and hypos for real-time CGM to both the patient and caregiver or healthcare team is also particularly useful. In the post-Ramadan period, I think CGM also helps to maintain good glycemic control because it provides constant feedback to the patient on foods and beverages to avoid during the festive season, and also helps in learning from experience for future Ramadan fasting. And secondly, when using CGM during Ramadan fasting, these are my conclusions. Now, in the future, I think there will be improved CGM devices, better accuracy, lower MARD, and less lag time. This all helps to improve the trust of patients as well as healthcare professionals in the use of these devices. It's important to counsel patients on the use of these sensor devices to address expectations, enhance understanding of how the sensor works in terms of lag time, interference, less accurate time points perhaps, particularly day 1, and loss of function near the end of sensor wear. And that it's important to confirm with a finger prick blood glucose in the following situations: when symptoms do not match CGM readings, in extremes of glucose readings, particularly in the hypo range and hyper ranges, and to treat hypoglycemia and hyperglycemia accordingly. And as seen in the study by Dr. Mohammed, best diabetes care practices plus CGM results in safer fasting during Ramadan. It's important to individualize advice to patients because there can be large inter-individual variability, whether it's cultural and family influences, personal dietary habits, or individual diabetes history or characteristics in terms of insulin resistance, diabetes duration, and residual beta cell function. The importance of Ramadan-focused diabetes education cannot be stressed enough. Medication adjustment pre-Ramadan in anticipation for hypos and what to do for hyperglycemia as well. And in terms of CGM, it may be useful for an interim CGM download to guide further adjustment for high-risk patients. With that, thank you for your kind attention.